Good morning, good afternoon, and good evening, everybody. My name is Sweta Saxena, and I'm a Health Systems Advisor in the Bureau for Asia at the U.S. Agency for International Development. On behalf of the Asia-Pacific Action Alliance on Human Resources for Health, the Secretariat, our hosts, organizers, and everybody working behind the scenes, I would like to welcome you to the 11th AAAH webinar series, where we are discussing how to address healthcare worker challenges in response to COVID-19. Throughout this series, we are sharing country experiences and lessons from the Eastern Mediterranean, Southeast Asia, and Western Pacific regions. Today is episode 3 under Webinar 1 series, which is on the topic of mobilizing surge capacity. We will be discussing how health workers are sustaining non-COVID services and essential services and maintaining quality of care in the context of COVID-19. We have an all-star lineup of speakers that will be providing many perspectives on this topic. We have academics, researchers, Ministry of Health representatives, multilateral and development partners, doctors, and the CEO. Today's outline of the session will be a moderated panel of 3 speakers and then a commentary. We will then end with a question and answer session. So please do send us your questions and comments via the Q&A function throughout the duration of the webinar, and we will be sure to get those answered. Please note that this session is being recorded, so you can watch this again and previous episodes once they are made available via the AAAH website. And please also bear with us in case we do run into any technical difficulties. I would like to now introduce you to our esteemed moderator, Dr. Palitha Abekun, who will speak more about today's topic and invite our other panelists to provide their insights. Although Dr. Palitha's full bio would take me a good 5 minutes to get through, I will just say for now that he is currently working in the Sri Lanka Ministry of Health. He was a former president of the Sri Lanka Medical Association, and he was former director of Health Systems Development in the WHO Regional Office in New Delhi. Thank you all again for taking the time to join us. And with that, I would like to turn the floor over to Dr. Palitha.
Thank you very much, Sweta, for your kind words. Good afternoon, good evening, and good day to everyone. Let me also add my own welcome to all of you. I also want to quickly thank the WHO, New Delhi, particularly my friend Dr. Thomas Zapata, the USAID, and the JICA for this privilege of moderating this 3rd episode of this webinar series. Let me first provide some context and a few comments before we hear from the distinguished panel. All of us have been passing through unprecedented difficult times, not over yet by any means, and it is extremely important that we share our experiences and learn lessons from one another as to how our health workers in our countries address the challenges in responding to COVID-19 and how can we do things better as we move to a new normal. Today's session is focusing on how we are sustaining the non-COVID-19 essential health services and maintaining quality of care, especially in non-communicable diseases, accidents, medical emergencies, and how we can restart these disrupted healthcare services, while at the same time controlling the virus itself, daunting. And all of these at a time when lockdowns, curfews, and travel bans are still restricting the movement of health staff and our supplies. With unparalleled disruptions to the supply chain of essential PPE, medicines, medical supplies, it demanded solutions beyond our normal ways of doing things. And our health staff rose to the occasion, improvised, and continued to provide care to the patients. Therefore, today, we are talking about our real heroes, the health personnel of our countries. The WHO conducted a web-based key informant survey in May 2020 to assess the impact of COVID-19 pandemic on 25 essential health services. Let me just share a few of these results that they have presented. In that survey, half or more countries reported that government policy had limited service delivery platforms, and 70% said this had affected community-based care, 50% said inpatient services, and mobile clinics. On average, countries reported partial or severe disruptions up to 60% of the 25 assessed essential health functions. Overall, the mean number of services disrupted per country was 14 out of 25, more than half. Disruptions of essential health services were seen in both service provision as well as in service use. They found that the most frequent and disrupted services included cancer diagnosis and treatment, dental services, NCD management, and rehabilitation services. These services were disrupted in 80% of the zero countries, though some services such as dental services or rehabilitation may have been intentionally reduced by government protocols. Many countries, 9 countries in Syria, had established packages of essential health services prior to the pandemic, and the majority had identified a core set of activities to be maintained. Quickly, what were the causes of these disruptions? We saw a mix of demand and supply factors. On the demand side, countries reported reductions in outpatient attendance due to public transport lockdowns and curfews. On the supply side, we had a range of factors such as decrease in inpatient volume due to cancellation of elective care, deployment to provide COVID-19 relief, sometimes no services available due to facility closures and disruptions in the supply chain. But the countries have responded to provide essential health services in multiple ways. Most commonly, triaging of health services, bringing telemedicine solutions, task shifting of health workers to new roles, and setting up novel supply chains for medicines. We will hear more details and specific experiences from the countries from the presenters very soon. Taking my own country, our health services prioritized a number of things, including dengue, which could have had disruptions to the public health services system further, along with to manage the COVID-19, and TB and sexual and reproductive health, and later MCH was also added. Continued services were on for routine dialysis patients. There are plenty in Sri Lanka who require this, and emergency services for NCD patients as usual. We rescheduled and postponed routine and elective procedures. With regard to essential medicines, even during the shutdown and the curfew, the pharmacies functioned providing continuous supply of medicines to their customers. Digital communications such as WhatsApp had been used extensively for sending the prescriptions. The government sent medicines by post and they were delivered to the people's doorstep. Pharmacists played a very major role here. The private sector was also very helpful and helped with medicine supply. This is by way of a brief background, and we will expand on this as we move. Now let me quickly share with you the slide on which we have the objectives of today's session. These are the objectives. Quickly, I will not go through the whole thing, but we will learn how countries are adapting their primary healthcare delivery models to ensure health workers provide continuity of care. We will compare lessons learned about the role of pharmacists in sustaining essential services coverage and how mobile technologies are being used to empower them. We will examine how countries are utilizing their health human resources information systems to manage and optimize their workforce. And we will also determine how best to engage the private sector providers to cover and to decrease essential service gaps. I will stop there thanking you. Next, let me move on to our distinguished speakers. Before I invite them individually, I think it's best that I introduce each of them first. Our first speaker will be Dr. Najibullah Safi, MD, MSc, Health Systems Program Manager in the WHO Country Office in Afghanistan. Dr. Najibullah is a medical doctor holding a master's degree in health policy and management from the Aga Khan University, currently working as a program manager of health systems development in WHO Office in Afghanistan. Before that, he was working as a Director General of Preventive Medicine and Primary Healthcare in the Ministry of Public Health in Afghanistan. Our second speaker will be Mr. Farooq Merali. who's the CEO of M Clinica Pharmacy Solutions. Farooq is the founder of M Clinica Pharmacy Solutions, a healthcare startup connecting pharmacies in emerging markets through a common mobile technology platform. And he held senior roles in strategy and product development at global pharmaceutical companies like Pfizer, Sanofi, and Roche. He is a recipient of the Harvard Alumni Public Health Innovator Award, an Endeavor Entrepreneur, and a board advisor at Path. And our third speaker will be Dr. Trisa Wahuniputri, who is the Secretary of Human Resources for Health Development and Empowerment Agency in the Ministry of Health of Indonesia. She is the Secretary of the Human Resources and Utilization Agency of the Ministry of Health. She has over 30 years of experience in health systems. And Dr. Trisa is a medical doctor with a master's in public health from the University of Erlangen. We have also our commentator for this evening, Dr. Haruka Sakamoto from the JICA Otaga Research Institute COVID-19 Response Comparative Research Team in Japan. Dr. Sakamoto is a primary care physician and assistant professor at the Department of Health Policy and Management at Kyoto University. She got her MD from Japan, her MPH at the Harvard T.H. Chan School of Public Health, and she has worked on health policy at the International Cooperation Department, Ministry of Health, Labor and Welfare in Japan. With that introduction of our speakers and the commentator, may I now respectfully invite, first of all, Dr. Najibullah Safi to speak to us on the country experiences from the Eastern Mediterranean region. Dr. Najibullah, it's yours now.
Good morning, good afternoon, good evening to audience and participant living in different, joining from different time zone and living in different countries. I would like to talk about sustaining non-COVID essential health services in the context of Afghanistan during COVID-19 pandemic. Before going to the details of discussion, I would like to provide you some brief information about the health sector of Afghanistan, and that will help you to better understand the situation of COVID and essential health services later on. The current health system of Afghanistan was laid down in early 2002, and then the Ministry of Public Health and partners, they focus to provide or to invest more in primary health care, and for that reason two different packages were developed. The first package is called Basic Package of Health Services, and that is focusing mainly on primary health care, and that was developed in 2003, and then later on revised in 2005 and 10. And for secondary care, in order to provide backup referral support to the BPHS, the Ministry of Public Health and Partners, they developed another package which is called Essential Package of Hospital Services in 2005, and that package is mainly focusing on hospital services across the country. You know that Afghanistan is still one of the country that instability and insecurity is common, and in certain area of the country, the government has a problem and limitation in accessing those area. And also when these packages were developed, so the capacity of government was quite weak. So in order to expand services quickly, the government decided to provide services through NGO under contract out arrangement. So in 31 out of 34 provinces of Afghanistan, all services are contracted out to NGOs, and NGOs are providing those services on behalf of government. The modality of contract was different on different location. It was revised, changed, and just since more than 2 years, the focus is more on uh, performance management and the payment of NGOs or link with 11 indicators. It has two component, a lump sum component and also pay for services. So 11 indicators are there that they are linked with the payment of NGOs. Overall, we had the midterm review of Sehat Mandi, which is the main primary healthcare program in Afghanistan. And the finding of that review indicated that utilization of primary and secondary healthcare services is reduced, and demand for emergency care and critical care is increased day by day. This slide indicates the status of COVID-19 in Afghanistan. Overall, to date, we have performed more than 100,000 tests, and close to 38,000 plus cases were found confirmed, and close to 1,400 people were registered that they died because of COVID-19. At the same time, a large number of healthcare providers, almost more than 3,600, were infected across the country. When the pandemic started, Afghanistan did not have the capacity to do tests inside the country for COVID-19. With the support from partner Ministry of Public Health, they established several labs, and till date, there are 11 labs across the country that they can do the testing for COVID-19, and plans are there to increase this number of labs and expand the capacity for testing. So the numbers of tests and the number of confirmed cases cannot reflect the actual epidemiological situation in the country. For that reason, the Ministry of Public Health decided to do a seroprevalence survey, and that seroprevalence survey found that almost 31.5% of the total population is infected, which is around 10 million people. And infection rate across the provinces, it's vary from one province to another province, but in Kabul, which is the capital and have a population of has a population of close to 6 million, almost half of the population, 52% of the population in Kabul were found infected with COVID-19. When we compare the data between the first quarter and second quarter of 2019 with first and second quarter of 2020, we can see that overall there is a decline in OPD, inpatient, and also bed occupancy rate. But if we look to the data for those indicators which are linked with payment, in the first quarter of 2020 compared to first quarter of 2019, we can see an increase in all those indicators which are directly linked with payment. If we see other indicators which are not linked with the payment, we can find that there is a declining trend in those indicators, including OPD, IPD, and bed occupancy rate. Hospital death increased, and a portion of that might be related to COVID-19 and also injuries and war. Those indicators which are not linked with the payment, and if we compare them for the first and second quarter of 2019 with the first and second quarter of 2020, we can see in most of those indicators we see a decline in the utilization of services. The Ministry of Public Health, in order to sustain the provision of essential health services, adopted the WHO strategic action for the increasing of utilization of essential health services. Within the structure of government, there were different platform which were responsible for coordinating different emergencies. For example, we had a EOC for polio, another EOC for CCC, Common Control Center for other emergencies. So with COVID, all these were brought under one umbrella, and those unit or those department which are responsible for the provision of essential health services like performance management office, grant contract management unit, they are all part of the committees which is looking after health emergencies and also provision of routine services across the country. The second component, we already have a package, and two packages, PPHs and EPHs, and we continue to provide those priority services. So within the existing context of COVID-19, there is no reduction in the provision of those packages. They are provided fully across the country. In order to build the trust and also encourage people to visit health facilities, in each health facility, a fever corner was established, and those patients coming with fever, they should go through different, I would say, to a relatively separate place. So that help to ensure that other people are not infected, and they continue to use the routine services. In addition of that, new hospital buildings were constructed, and also some of the hospital were repurposed, and they were only allocated for COVID-19. So that also helped to make sure that the provision of routine services in other hospitals, they continue. At the same time, the infection prevention and control measures were expanded. Training were provided to the healthcare providers, and that's still going on. For public awareness session, and through different means, information were provided to how to prevent from COVID, and also learn to how they can safely seek care in health facilities. Almost during COVID-19, when the pandemic started, the Ministry of Public Health called for volunteers, and more than 10,000 medical doctors, they registered themselves with the Ministry of Public Health, and some of them were deployed when needed. Detailed and comprehensive training program on COVID-19 were designed, and they were offered to the existing healthcare providers, and also to the one which were registered and in a waiting list. If required, they will be deployed. So training was conducted for them. On ensuring supply chain, as the BPHs and EPHs are contracted out to NGOs, so NGOs continue to provide medicine and to the health facilities that they were responsible for. And in addition of that, the government allocated additional budget, but that additional budget were mainly for COVID-19, and at the same time, partners also allocated, partners and donors, they also allocated a significant amount for COVID-19 response, and also continuation of existing health services. If we just mention, only World Bank invested more than $100 million for COVID response, and also continuation of essential health services. EDB invested almost $40 million, and EU, some discussion, negotiation is going on. So they will invest and support certain programs in coming weeks. All the services to the population are provided free of charge, so there is no financial barrier to access services. Different communication means and channels were used to provide awareness for the public and also for the healthcare providers. The intensification of monitoring by different department within the Ministry of Public Health, which include Performance Management Office, Grant Contract Management Unit, and also the E-Mini Directorate, and at the provincial level, the provincial public health directorates. They continue to monitor the provision of existing services. In addition of that, the large network of polio, as you know, Afghanistan is one of the two remaining endemic country for polio. So we have a large network for surveillance and also for campaigns. So that polio network was also used to assess in COVID surveillance and also to do the monitoring of the essential health services across the country. Data in HMIS and also through monitoring data, available data is disaggregated by age and sex, and that's available. In addition of that, the Ministry of Public Health and partners, they try to use a different digital platform to support the provision of essential health services and also COVID response. So DHIS2, which is used as a platform for merging different data sources, and that is expanded. A dashboard for COVID-19 was developed. Mobile companies, they provided or they changed their ringtone to messages related to COVID-19 prevention and how to use the existing health facilities. So they are focusing on that one. And for the first time in Afghanistan, the government and the medical council, they provided online training courses for COVID. So people from different provinces and healthcare providers can attend and get benefits out of those available online programs and courses. If we conclude, we can see a mixed picture of the impact of COVID-19 on essential health services. Overall, we see a decline in OPD, IPD, and bed occupancy rate. But if we go in depth and further analyze the data for those indicators which are linked with payment, we see less differences, and even on some occasion there is slight increase in utilization of those services. While the indicators which are not linked with payment, we can see a reduction in those indicators. I think beside the challenges that the COVID imposed on us, it was a good opportunity also to draw attention to the health sector and also more investment even from government of Afghanistan. For the first time, they invested a lot as compared to their past investment within the health sector. So ICU care was improved and expanded. Infection prevention is much better now as compared to the past, and capacity building of staff that's going on, and lab network has been expanded rapidly, and this expansion is going on. Also, because of COVID, I think the coordination improved, and different departments responsible for health emergencies and also for the provision of routine services, they are brought together, working under one umbrella in one platform to better coordinate the provision of existing essential health services and also COVID-19, responding to COVID-19. With all this, I believe that the health sector in Afghanistan is much more better prepared to respond to any potential second wave of COVID-19 and also other health emergencies. Thanks. This is all from my side. If there is any question, I will be happy to respond. Thanks a lot and have a nice day.
Let me very kindly invite our second speaker, Mr. Farooq Merali, CEO of M-Clinica Pharmacy Solutions, who will be speaking on the private sector experiences with pharmacy solutions in the Asia region.
Well, thank you, everyone. It's good to be part of this panel here today, and thank you for the kind introduction. just to give you a little bit of background, today we're going to cover the role of pharmacists, which is often a little bit uncovered in COVID-19, talk. And so we'll take you through some of the experience of working in the field with this particular demographic and looking at how the role of technology has helped to accelerate their role in community health, looking at it as treatment of non-COVID-19 care during the time of this pandemic. So first of all, I think, to set some context, pharmacies are very critical to public health. And, I think many of you who are living in these countries, I myself am based in Jakarta, Indonesia, and, you can clearly see the role of pharmacies here and how they become the first point of care for patients. And in many cases, as patients go and seek community care, the pharmacy is the first case. It's very accessible. There's not a lineup. There's no fees. There's no sort of insurance claim system. They can very easily access care at the pharmacy. There's long hours of availability. And I think, this is the situation across Southeast Asia, but across many lower middle income countries generally. And I think pharmacies were so critical during the pandemic time. And today we'll share with you some very interesting data about the role of pharmacy specifically during COVID-19 and how they took on an even greater role in community care for not only COVID-19, but also other care areas as well. So I think one of the challenges of dealing with pharmacies has been, that pharmacies across Southeast Asia, as well as many lower middle income countries, are generally fragmented independent pharmacies. So when you're thinking about public health programming, it becomes just very difficult to access these pharmacies. How do you actually run a public health program, whether it be for TB or HIV/AIDS or AMR or even COVID-19 at scale, given the fact that these pharmacies are located in very geographically disparate areas? They're largely mom and pop shops running on pen and paper. There's no real digital systems. And if we think about it as an effective public health channel, there is a real need to kind of bring these pharmacies together. And this is really the role of technology during this process. So I think, if you look at the photos on the left, I think many of you will be very familiar with pharmacies like this. And these are the community care pharmacies. And if you look at, for example, Indonesia, 92% of the pharmacies are independent. Vietnam, 96%, and so on and so forth. And so when you have this situation, it's very hard to get to the pharmacy workforce. And this is really where the end patient challenge is. So what we did at mClinica is to really connect all these pharmacy professionals together using this app called SwipeRx. And so that was a modality of using a mobile phone app to actually connect pharmacy professionals together and provide all their education, information, question and answer, ability to do everything from report adverse events to the FDA, to do case reporting and referrals. And what's interesting is, as a result of launching this app, we put about 170,000 pharmacy professionals across Southeast Asia on this app. For example, 1 in every 3 pharmacists in Indonesia is on it, 1 in every 2 in the Philippines, 1 in every 3 in Vietnam, 1 in every 4 in Thailand, Malaysia, Cambodia. So across Southeast Asia now, you have a very important healthcare segment, the pharmacy, that is now digitally connected. And what this creates is incredible opportunity for a situation that we just went through with the pandemic, where you really need real-time communication. You really need the ability to get to a large audience very quickly. You need to be able to gather research and data and then help to train these frontliners who are dealing with unprecedented patient volumes and potential case exposure as well. So, really, once you have them all connected, there is really a kind of pathway that we consider of how you can move the frontliners from just understanding what's going on all the way to actioning improvements in competency and capabilities that end up affecting the end patient. And so all the way from research, education, awareness, to even referrals, all of this can happen through a fully digital pathway. And so, we have been using SwipeRx to work with, aid agencies, for example, USAID. We work with WHO. We work with many of you who are on the panel today in various different ways in different disease areas. But today I'll focus on the opportunity of using technology for pharmacies during COVID-19, but specifically around how pharmacies were affected in non-COVID-19 care. So, since the first reported case of COVID-19 across Southeast Asia, the partners and our technology kind of sprung into action, and together there was a multi-country response that was mounted for COVID-19 using a digital channel. So, across the region, very quickly, as early as March, when the first cases were kind of emerging, I remember March 2nd was the first 2 cases in Indonesia, for example. We worked very closely with ministries of health in Indonesia, Cambodia, the Philippines, pharmacy associations who are actually present to ensure the capabilities and capacity of the actual professional trade, as well as donor agencies, academic institutions, and implementing partners in order to mount a COVID-19 response digitally through the pharmacy. And I think the general perspective was that even if you look at news coverage during the time, a lot of focus had been on really hospitals, clinics, doctors, nurses. But we felt, and the partners felt, that it was very important to strengthen the response at the pharmacy level because of their critical role in community health and their exposure to large amounts of patients. So what was super surprising to us was that during COVID-19, actually, patient traffic to pharmacies actually increased during the period. And while there were social distancing measures, in certain cases quarantine, we are looking at Indonesia data here, but this was actually very common in the Philippines and Cambodia as well. We actually saw a 24% increase in patient traffic to pharmacies during COVID-19. And here's the thing, they weren't necessarily going to consult about COVID-19, but they had their other chronic conditions or other acute conditions that they were seeking care at the pharmacy. Now, the reason why, in digging a little bit deeper as to why patients were motivated more to come to pharmacies was, number one, hospitals and clinics were actually either closed or at reduced hours. Number two, hospitals and clinics were not necessarily admitting non-essential cases. So if you were, for example, a diabetic or you're hypertensive or you had a particular oftentimes hospitals would say, no, we can only take COVID-19 cases or acute or severe cases. So as a result of limitations, especially on the private sector clinics and hospitals that were kind of closing down or not taking non-essential cases, we found that. The other thing we found was that actually patients feared going to hospitals and clinics for anything that was not COVID-19 for the fear that they potentially could contract it themselves. And so all of these factors actually led increased patient traffic to the pharmacy. And that was quite surprising in terms of the research that we were able to conduct during the period. So what's also interesting is that pharmacies became this very critical point. We saw that footfall actually increased to the pharmacy, but actually 50% of patients during the period sought advice on COVID-19 at the pharmacy. So in an era where, there is a lot of different information and oftentimes, fake news or fake information that abounds on social media and other networks, they actually solicited advice at the pharmacy on COVID-19, them being considered as a trusted source of care. Interestingly, 39% of patients during the period complained about COVID-19. Now, whether that is a fever that is potentially presenting as possible COVID-19 or the like, it is unclear, but certainly there was a lot of indication of patients actually presenting with COVID-19 symptoms. And actually what's interesting is when you track actually purchased data on fever and even cold medicine during the period, we saw a 50% spike in actually purchased data for this. And so this is really quite interesting because what it shows is that patients were actually visiting pharmacies for COVID-19, but also other symptoms that they were actually presenting in for other conditions. So what's also interesting is during the period, and this goes specifically at non-COVID-19 care, 32% of patients actually asked pharmacy professionals for counseling on chronic conditions at the pharmacy, citing their inability to access clinics and hospitals. So what we see here again is that patients are not only moving in greater volumes to pharmacy, but actually they're increasingly relying on pharmacies for that counsel, for chronic conditions and the like, because they're unable to see a doctor during the period. They're unable to access hospital and clinic care. And so this has created an increased reliance on pharmacy professionals, which means that pharmacy professionals need to have that education and training to be able to give the accurate advice to patients, which is very critical. So the other thing that we found during the period, and this was something that even Professor Palita actually spoke about, was that supply chain was very affected during the period. And what we found in Indonesia, as well as the Philippines and Cambodia, where we did most of the COVID-19 response at pharmacy, was that 81% of the pharmacy professionals reported a lack of medical supplies from wholesalers and distributors. This data was particularly acute in April when we ran the analysis, but we also measured May, June, July, and only now are we seeing actually levels increase back to normal results. And I think one of the key things to think about is that actually when the pharmacy does their purchasing from a wholesaler, wholesalers also had limited hours of availability. They also were doing reductions in staff. They were doing reductions in throughput, wholesalers and distributors. So the simple physical logistics around supply chain were actually brought to a little bit of a pause, or at least lower capacity. Moving upstream even more, you're looking at pharmaceutical manufacturers who are importing a lot of drugs or even API ingredients to manufacture locally. And supply chains were disrupted. If you think about it, in China, as it first broke, supply chains there were affected. And because a lot of the API and basic ingredients in manufacturing come from China, other global supply chains were created. So what you saw was a little bit of a phased approach where issues in one geography due to a globalized supply chain started affecting local supply chains as well. So luckily we've seen this quite catch up. And I think, that made that the particular issue of patients being able to access, drugs for their normal chronic conditions or non-communicable diseases very critical. We also saw this in issues around infectious disease. For example, access to tuberculosis medicine was actually compromised during the period. We saw this in Philippines and Cambodia as well, as supply chains and access to TB meds was constrained. So while we were dealing with one pandemic of COVID-19, we potentially create another issue in terms of non-COVID-19 care. And access to supply chain through the pharmacy was very critical. Next slide, please. So, now we know, right, pharmacies are very important. We saw footfall increase during the period. We saw them becoming increasingly used as a trusted source of care and counsel for patients. But then they were, having major supply chain constraints. The other constraint is actually their level of education information. And my key takeaway here is to understand that pharmacies are super critical in terms of community care, often more so now than ever. And I think, what was quite surprising when we did the analysis, although, health information was changing so rapidly, it is understandable, was that 53% of pharmacy professionals in April, when we did this test, actually got the symptoms of COVID-19 wrong. 96% got the criteria for rapid testing wrong. 70% got criteria for hospital referrals wrong. And 56% of pharmacy professionals stated the need for further education for counseling. And so I think what this tells you is that, look, there is a basic information gap that needs to be strengthened. And there is an appetite that pharmacy professionals have for actually learning more, for being able to provide accurate counseling, not only just on COVID-19, but non-COVID-19. As volumes increase, as their role as counselors actually increases, they need to be equipped with how to properly counsel. And I think this is the role of digital education, digital engagement, and the like, which is a lot of the work that we do. Next slide, please. So I'll stop here with this last slide. And I think this is a particularly powerful slide. And this is a pharmacist in Indonesia. And, she says, my pharmacy remains open, right? And the reason it remains open is because the pharmacy provides health services. And I think during that period, it is a moral and professional responsibility to continue serving in any situation. Has there ever been a time when there were no sick people? So the pharmacy must still serve. And I think that's very powerful because no matter what, whether COVID-19 or the pandemic, the pharmacy remained open and they actually became such a critical point of care during the period. And they continue to be a critical point of care, not only for COVID-19, but non-COVID-19 care as well. So I'll stop there. Thank you very much for the time.
Let me quickly next invite the next speaker, Dr. Trisa Wayuni Putri from Indonesia, who will present her experiences from Indonesia. And the title will be using HRIS dashboard for HRH distribution plan. Please, Dr. Trisa, it's yours now.
Thank you, Professor Palita. Greetings, our moderator and other speakers, Mrs. Sweta Sasena, Professor Palita Abiokun, Dr. Nazibullah Safi, Mr. Farouk Merali, Dr. Haruko Sakamoto, and all participants of the third episode of the first webinar of HCWs. As it happens in any countries in the world, Indonesia is also struggling against COVID-19. The picture above is an overview of COVID-19 in Indonesia, and current now total cases around 160,000 people. Confirmed cases are still high in several provinces. An overview of Indonesia with a population of around 267 million people with an archipelago of more than 17,000 islands. It is the top 5 most populous countries in the world. Indonesia has approximately 1.2 million health workers who work in around 3,000 hospitals, both government and private, and supported by around 10,000 public health centers. What are the challenges that Indonesia currently experiences? To begin, Indonesia is facing issues with maldistribution, with overstaffing in urban areas and understaffing in rural areas. In addition, we are seeing production of certain types of health workers that do not align necessarily with a population health needs. Finally, we are also seeing a lack of coordination of stakeholders within the health labor market. These overall health human resource challenges are further compounded by COVID-19, where health workers are being faced with increase of workload, at risk for infection, and struggling to maintain their motivation as the pandemic continues on in the country. Challenges with HRH data have impact the ability of the government to respond to their issues. Specifically, human resource health data issues in Indonesia revolve around lacking completeness and accuracy of data on health workforce and limited integration or interoperability between the various health workforce information systems. In addition, data is usually analyzed in silos, with health workforce data rarely combined with services data, so we can better understand that workload health workers are facing. And we were seeing issues with poor presentation of data, limiting the ability of stakeholders to truly understand what the data was telling us, to better inform policy or planning. Overall, these challenges are exacerbated of COVID-19 as stakeholders need access to real-time quality of data to make a quickly decision. To address these challenges, the Human Resource for Health Agency, this is our unit, identify the following solution as necessary to ensure that Indonesia was able to respond to COVID-19 while maintaining essential services. First, a multi-sectoral policy agenda was developed. Then, efforts were focused on strengthening and use of human resource information system of the country to both inform and serve as a catalyst to implement the policy agenda. And finally, tools were developed to analyze and visualize data for use when carrying out the policy agenda. This will be a continuous cycle where information system is used to produce reliable data and analyze to inform and strengthening a policy agenda. So, how do we know that the solution that we propose will be successfully? I will be sharing the policy environment in Indonesia around information system and its ecosystem. In recent years, Indonesia has put a strong focus on the health workforce, information system, and data use. Specifically, our 2020 up 2024 in Midterm National Development Plan, various presidential decrees and government regulation, and of course, our commitment to the global strategy of human resources for health in 2030 truly demonstrate the enabling policy environment that exists in the country to support our essential health services. With the current COVID-19 response, we have put a renewed and a strong focus on further leveraging existing policy and investment around information system that will enable us to make evidence-based decisions to support the health workforce to both respond COVID-19 and maintain essential services. Now let's look closely at what we did. There are three approaches that we adopted. First, we make sure that all stakeholders at all levels are engaged. Next, we build on the existing system to ensure complete, accurate, and up-to-date data on health workforce are available. Then, we improve the data analysis and visualization. These are our efforts to increase use of data to augment and support the health workforce with a goal that we establish a responsive and resilient health system to respond COVID-19 and maintain essential services. To illustrate the approach I mentioned just now, I will focusing on the volunteer and incentive program. To support the health workforce to respond COVID-19 and maintain essential services, the government of Indonesia developed a volunteers and incentives program which aim to ensure that health facilities are able to both respond to COVID-19 and conduct essential services. To carry out this program, the Ministry of Health engaged stakeholders from Ministry of Finance, Ministry of Home Affairs, and the regional level to develop a policy for recruitment of health workforce volunteers and mobilize incentive for payment of these volunteers. Then we built on previous investment in strengthening of the human resource information system to rapidly including additional data on the health workforce as well as additional COVID-19 specific workload data to then use the system to plan for and carry out to volunteer and incentive programs. Finally, we expanded on this existing data analysis and visualization platform, creating dashboard and data set for stakeholders to use to monitor the health workforce as compared to the COVID-19 situation, as well as the volunteer and incentive program. Before we deep dive into the volunteers and incentive program, here is an example of one of our public-facing COVID-19 HRH dashboard showing COVID-19 cases as compared to referral hospital and number of health workforce in each hospital. As you can see, users can filter by type of health workers and type of cases, positive, recover, death, or other condition. This data is updated daily in near real time through use of web APIs to official COVID-19 data and the human resource system for health workforce data. Through noted before, it should be emphasized that the system to create the human resource health dashboard was in place prior to the pandemic. It is currently being used to better analyze the status of health workforce to maintain essential services. This previous investment allowed us to act rapidly, building on the existing structure for COVID-19 response. As one of the data utilization human resource for health information system during this pandemic, how to utilize existing data to mobilize health workers and area with high cases to low cases according to the type of health personnel and the number of health personnel available from high density to be seconded. There are approximately 13,000 volunteers who have been coordinated to fill the newly established emergency health facilities and health facilities that are short on health personnel due to the increase in cases of COVID-19. There are several schemes that we have, including like a volunteer scheme from professional organization, volunteer scheme from fresh graduates, through Health Nusantara, or we call it Nusantara Sehat. Indonesia is samely with Nusantara, and the Indonesian Doctors Internship Program. Internship is a process of increasing the capacity for newly graduated doctors through apprenticeship internship. As previously mentioned, prior to COVID-19, Indonesia invested heavily in strengthening health human resources system and Indonesian information system and developing a data analytic platform. The platform is used to monitor all aspects of the health worker life cycle, such as understanding where is a midwife graduate, as well as where health workers are active compared to, for example, maternal mortality, like in this picture. So human resource for health agency is actually working with the Indonesian Midwifery Association to create interoperability between the association information system and the human resource for health agency system to increase the availability of quality data between the two systems by interoperability. By knowing where our health workers are compared to health trends in emergency such as COVID-19 and essential services such as newborn maternal health, we are better. COVID-19 will still be with us for some time, but we still need to ensuring the maintaining of essential health services so that the secondary impact of the pandemic on health outcome is lessened. In terms of next step for COVID-19, Indonesia will conduct the following. Firstly, continue to empower national and local governments, specifically on human resource health management from planning, procurement, deployment, and empowerment. And secondly, disseminate tools to promote health workforce data analysis and use at the national and local stakeholders levels. And finally, use the data analytic platform to develop recommendations to improve volunteers, incentives programs, health education, and training. In terms of maintenance essential services, Indonesia will use the human resource information system to inform to 2021 deployment and other redeployment of human resources, and continue to strengthen quality of health workforce data to build confidence in the data and human resource information system by users, ultimately leading to an increased use of health workforce data from human resource information system into policy development and action. That would be all my presentation for today's topic. Thank you for all attendees to spare your time. We greatly appreciate this opportunity to participate and share our learning from Indonesia. Let's
Thank you, Dr.
continue.
Thank you very much.
Thank
Well, very, very interesting, very comprehensive presentation. Thank you. Like you would have seen on the screen, we are running a little bit behind time. So some of the questions which are available on the screen, Shweta thinks that you might be able to answer some of them on the screen itself, that we can save time. Otherwise, we'll take them up soon after the commentary. We hear the commentary from Dr. Sakamoto. Dr. Sakamoto, please.
Hi. Thank you very much for giving me the floor, and thank you for all the panelists for the wonderful presentation. As most countries experience the excess deaths, our COVID-19 revealed that not only the control of the COVID-19 was not enough, but it also revealed the difficulties in providing essential healthcare services. So all the countries continue their efforts for providing essential health services during this crisis. And then in this regard, we could learn many good lessons from all the panelists. First, about presentation by Dr. Najibullah Safri from Afghanistan. Thank you very much for sharing the situation in Afghanistan. There were many lessons included, especially how people in Afghanistan overcame the challenges posed by the COVID-19. I am particularly interested in the strategy for sustaining non-COVID-19 essential services, which focuses on coordination and governance. As the infectious disease department alone cannot manage the COVID-19 and other essential health services, I think it is very important to promote sectoral collaboration and good governance. And it also relates to other presentation, but I agree that utilizing the digital platform, including the data management, is the key for success in continuing essential health services. And then next about Mr. Falok, thank you for your presentation. And it was particularly interesting to me that the patient went to pharmacy not only for seeking medicines, but also they are seeking for counseling and other services. I strongly agree with the importance of pharmacists, especially for the NCDs management. Because the most NCD patients take any medications for hypertension, diabetes, and other chronic conditions. But due to the COVID-19, most patients face the difficulties in keeping these medicines. So in this regard, the role of pharmacist is very, very important. And I was also amazed that you were doing the research in parallel for assessing the impact of the pharmacy. I think this research finding provide useful feedback for countermeasures for COVID-19 and also for the other health services, such as strengthening the education for the pharmacist. Lastly, about Dr. Torisa from Indonesia, thank you very much for sharing the situation of human resource for health in Indonesia. The challenges such as maldistribution of human resources and then keeping motivation during the COVID-19 pandemic are the common challenges globally. And I think most countries face the same challenges during the COVID-19. So what was particularly interesting to me was how Indonesia overcame these challenges in terms of the data management. What is different from the pandemic 10 years ago is that we can now use the technology and data. And then I believe that data governance is particularly key for controlling the COVID-19 and future pandemics. But there's always a debate about data governance and privacy issues. So in this regard, how Indonesian government utilizing the data, utilizing COVID-19 as a political window for promoting data strategy is a very good lesson for many countries. So now I'd like to briefly explain about Japan's situation. According to the National Institute of the Infectious Disease in Japan, there is no excess deaths between January to April this year, which indicates that Japan could keep providing essential health services, especially for the emergency care for the early phase of the COVID-19 pandemic. So in Japan, hospitals that treat certain infectious disease like COVID-19 are determined by law. So as a result, there's a certain degree of separation between the hospitals that treat COVID-19 and those that do not. So there was likely no significant impact on non-infectious diseases. However, there has been a decreasing trend in essential health services, such as immunization for children and then cancer screening. Also, there's no official data yet, but some physicians say that, especially for the chronic disease, such as hypertension and diabetes, they were facing challenges continuously providing the services for patients. So main reason behind are the patients themselves stopping to go to the healthcare facilities because of fear of being infected with COVID-19. Also, healthcare facilities had to close for a time, mainly due to the shortage of the PPE. The government encouraged online consultation for both healthcare facilities and patients, but there may be a negative impact to some degree for patient health status and the quality of life. So further research is needed to assess to what extent COVID-19 posed an impact on healthcare service delivery in Japan. So I think we are now running out of time. So I'd like to stop talking here. Thank you very much for giving me opportunity today again. And then now I'd like to return to the moderator. Thank you.
Thank you. Thank you very much, Dr. Hakamoto, for your very succinct, very pointed comments and also the information on the situation in Japan. Thank you very much. Now, let us now move to the next segment, which will be the Q&A session. There are, as you might have noticed, there are some questions on the screen, which you can reach on the screen. And one of the things that Shweta was saying was that maybe in the interest of time, some of these can be answered on the screen. But shall we start off by doing it all together? If we have all the panelists on the screen, we can see how we do with this. There are, I can see 6 questions on the screen. There may be others coming in. Shall we start with?
So I've answered in the dialog box, but I'll just quickly go over a few of the answers. So I think one of the answers, one of the questions was around because pharmacy professionals had increased exposure of COVID-19, what was the response to actually protecting pharmacy professionals in the first place, which is a great question. A lot of that had to do with dealing with the supply chain constraint in the very beginning. So at the beginning, supply chains were incredibly constrained. PPE was not being produced at the rates and volume that it needed, especially from frontline healthcare workers. We saw that in Philippines, Indonesia, Cambodia. And so, one of the key things we did was ensure that, pharmacies had access to face shields as well as masks in priority. We did that 5,000 different pharmacies in about a 2-week period to make sure they were covered. Luckily, what we did see was that supply chains actually started to rebound, and then manufacturing was repurposed. Factories were once textile factories became mass factories, actually in quite quick order, and that problem started to ameliorate itself. At which point, they were able to procure on their own. The other question is from Myanmar. So, what was the response after you found out about the challenge of COVID-19 at the pharmacy? What was actually done about it? What were the actions taken? So the first thing we did was understand a baseline of protection at the pharmacy with respect to COVID-19. Once we had done that, it was about driving action. So the first thing we did was work with a variety of partners, including Johns Hopkins and academic institutions, to create education and awareness and engagement content. So in about 5 days, we educated 4,000 pharmacy professionals online. And that was, a very big digital push. The COVID-19 material told them about symptomatic presentation, what to actually counsel a patient on, how to refer, and the like. And then beyond that, because we have this very large sort of digital network called SwipeRx that's multi-country, we were able to target valid, trusted, accurate information based on the latest WHO guidance and local Ministry of Health guidance to about 56,000 pharmacy professionals. And that reached an estimated 9 million patients. So I think what's quite interesting is by tapping sort of a digital response and working with partners from, Kemenkes in Indonesia, all the way down to Department of Health in the Philippines, Ministry of Health in Cambodia, along with various different academic institutions, driving sort of digital change at the pharmacy level. You not only just did research, but you were actually able to drive it. Right now, we actually just did a post-test where we were able to determine, did these digital interventions of education and awareness actually drive change? And the result was quite significant. So I think that's quite interesting in not just the COVID-19 situation, but looking at digital response to healthcare frontliners in any pandemic or post-pandemic situation. And then the last question here quickly is, did because of there being constraints at the supply chain level, did pharmacies actually recommend alternative medicine, i.e. did they switch therapy? And so what we did notice was we didn't do this particular study within the context of COVID-19, but generally switching at the pharmacy occurs about 22% of the time across Southeast Asia. This is from data we have from a multi-country basket. What that means is they can switch a particular brand or manufacturer for the same molecule, or actually substitute the therapy entirely, right? And so, our assumption is that during COVID-19, based on the supply chain constraint, that level of substitution increased. So it's already pretty high anyways. We think it did increase. And the last question was around, what do you see the role of the pharmacist in primary care over the next 5 to 10 years? And what do you think are the major challenges? So this is obviously a big question. I could spend an hour talking about it, but the short of it is, I think right now, very much pharmacists are viewed as drug sellers. I studied public health, and I think I remember the word pharmacist only being mentioned twice in a 2-year period of studies. And I think it is very not well covered. And they're a very critical segment. They're often referred to as sort of drug sellers where you just go and buy. But we see that very much evolve. It's even more important in sort of lower middle income countries. So where we see that progression is less as drug seller, more as community healthcare practitioner. And we see the pharmacy not just as a retail shop that you buy your drugs from, but actually as a community health hub. And I think the digital transformation that will help them to get there will actually accelerate this. So that's our vision and view, that pharmacy professionals are oftentimes the unsung heroes of public health. But we believe that with digital tools, empowerment, and increasing the awareness of the criticality of this particular workforce, it becomes even more important. So I'll pause there. Thank you.
Thank you. Thank you very much. Yeah, very, very good answers. We have a number of questions for Indonesia. Dr. Trisa, can you see the questions that are directed to Indonesia? Would you like to quickly?
Yes, this question from Riksa Wibawa Resna, I think, is what are the main obstacles for the Indonesian government to able to quickly deal with the COVID-19 problem that continues to develop until now? Yes, I think when Indonesia was first hit by a pandemic, we were busy to preparing health workers, especially doctors, specialist doctors, and nurses, as the front line to handle the high cases in early March, April, and May. And then after that, the government busy how to make a massive case finding, and Indonesia is targeting laboratory tests current now up to 30,000 daily. So it means that we need special health workforce, like laboratory technology experts. And then in the current phase, like we are entering in the new normal, we have to change the behavior of the community. We need a lot of personnel in the field that able to do health education and promotion to change from their previous behavior. And this requires professional public health and health promotion. So I think the question, I think the problem that we continues to develop until now is different, step by step, and we and we rely on with the current situation. I think so.
Dr. Trisa?
Yes.
Dr. Can you hear?
Yeah.
Trisa, can you hear? Can you answer this and then we can move on? Can you answer this question? What were the kinds of incentives that were offered to health workers and also the volunteers? Very quickly, some response to that, please.
Yes. As I mentioned previously, that Indonesia has 3 schemes of the volunteers. For the first and the second, first from professional organization and the second from the fresh graduates, government give additional money per month, but for the third scheme, we call it Nusantara Sehat, or we call it Health Indonesia. We offering to them to continue the education or scholarship, like continue the magister, or if doctor, continue to the specialized. And also we offering for the civil servants, like that.
Yeah.
So this is the incentive for the volunteers.
Yeah, thank you. Can I now turn to Dr. Najibullah? And there was one question from for you. I don't know whether you saw that.
Yes, I said and I responded there. I can briefly talk about it here also.
A quick comment, Dr. Najibullah, on that question directed to you, please.
Well, there were two questions. One was talking about the percentage of healthcare providers.
Can
Uh,
can you elaborate on the criteria to define essential health services from your initial list of BHPS and EPHS? Which services were selected and why? That's for you.
Well, this is the basic package of health services was developed in 2003, and it's mainly focused on maternal and child health and communicable disease. And these were the three major problems in Afghanistan at that time, and still these are the major problem and priorities for the country. And also there are some supportive elements for that one, which include the provision of essential medicines and supply. That's part of that. So the basic package of health services mainly focus on maternal, child health, and also infectious disease control in Afghanistan.
Thank you.
You're welcome.
I think we have answered all the questions on the thing. Any panelists notice something that has not been addressed yet on the screen?
I think there was one to Dr. Teresa about how are they ensuring they're engaging all stakeholders in Indonesia. I think perhaps it might be interesting to understand if there's been a different approach to engaging private providers.
Yeah, please. Why don't we quickly hear what happens there?
Yes, thank you for the question. I think it is a very difficult. It is not easy to make engagement in the multi stakeholders like in our country also. So what we can do in Indonesia, we have we call it gugus tugas, or with a task force, special task force to coordinate all stakeholders, all ministry like Ministry of Health, Ministry of Finance, Ministry of Internal Affairs, and etc. So in terms of the health information system, we have a coordination. We have make a coordination with many stakeholders, and in terms of COVID-19, the coordination increase rapidly and automatically. So this is our this is our lucky. I think we have advantages from the COVID-19 because our collaboration better. Our coordination is more easy. Thank you.
Thank you. Thank you. I think we have covered all the questions. I don't see any more on the screen. There's one about attrition rate among health workforce, not addressed to anyone in particular. I don't know whether we should take it up now. I think we are closing on our time. Time is up. So maybe let me first of all thank all the speakers and the commentator for the wonderful informative and interesting presentations they made. We learned a lot from your presentations. And I think overall, if I am to make some overall impressions that I got, I learned very much from all the countries how the demand for essential services changed as a result of COVID-19, and how the different countries use different strategies, different innovations to mobilize human resources to respond, particularly at the primary healthcare settings. And I also learned that to ensure the continuity of care, how countries adapted their HRH models in primary care settings, how some of the countries engaged the private sector as well as community health volunteers. We learned a lot about the role of the pharmacies in sustaining essential services, supporting the rest of the health workforce. And in fact, we learned that the pharmacies have a very, very important role here. They are critical now in the current context in public health, especially during these pandemic situations. Because we learned that in some of the countries, they are often the first point of care and the counsel for patients. We also saw how digital tools helped in improving the education and engagement of pharmacy professionals. And we learned from Indonesia how the countries utilize human resource information systems to support their health workforce, planning, recruiting, and the whole works. These are all good lessons for us. And I think I will not take any more time to elaborate. I have a lot of things I could say, but let me once again thank all the panelists, thank the WHO, thank JICA, USAID, and in particular Shweta and Thomas for all the help up to this. Thank you very much, and let me now request Ms. Shweta to kindly close the session and make any announcements. Thank you very much once again. Good night.
Absolutely. Thank you so much, Dr. Palitha. And thank you again to Dr. Safi, Farouk, Dr. Teresa, and Dr. Hugra, and AAAH, and our hosts from WHO and JICA as well. I believe at one point we had a bit over 160 participants join the webinar, so a big thank you to the audience, and thank you again for your questions. We hope that you enjoyed today's topic on how healthcare workers are sustaining essential service coverage and non-COVID services. And we hope that you did learn something new. Today was the last episode under Webinar 1 topic of mobilizing surge capacity. But we would love to invite you to join us on Friday, September 11th at the same time. We will be starting the Webinar 2 series, which will be on the topic of occupational risk protection of healthcare workers. So please do keep a lookout for the new registration link on the AAAH website. And with that, I would like to bring the Webinar 1 series to a close, and thank you again.